রফিক ভাই আসছে?
না, রফিক ভাই একটু বাইরে আছে, তবে উনি জয়েন করবে। হাফিজ, আমি আজিজ বলছি। হ্যাঁ, কেমন আছো?
Sir, we are live now. You can start.
Okay. না, রফিক ভাই জয়েন করবে, কারণ মাছ মারতে গেছিল, ধরতে পারে নাই।
Tushar, start please.
Assalamu alaikum, Hafiz bhai.
Tushar, start please.
Yes, sir. Assalamu alaikum and good evening, dear physicians. Today is our 47th lecture session, and today's topic is non-ST segment elevation MI. But before going to that particular topic, I request Professor Abdulwahid Chaudhary sir to speak on a very special occasion on 15th August. It is the next Sunday, and then we introduce our speaker, today's speaker, which will be done by Professor Antiplatelet Therapy. So I request Professor Abdulwahid Chaudhary sir to say some words regarding 15th August. What is sir?
Good evening, everybody, and assalamu alaikum. This is the month of August. It has a particular importance in the life of every Bengali. This is the month when we lost the father of the nation, Bangabandhu Sheikh Mujibur Rahman, along with his families. And this is a very sad month, also a month of resolve. Our father of nation not only gave his life for this country, his family members also sacrificed. And we who are living, who are enjoying the benefit of this country, we should be paying our respect through our action. বঙ্গবন্ধুর স্বপ্নকে যদি আমরা সফল করতে চাই, তাহলে আমরা প্রত্যেকে নিজ নিজ কর্মস্থলে, নিজ নিজ জীবনে সেই প্রত্যয় নিয়ে, সেই দেশপ্রেম নিয়ে, সেই নিষ্ঠা নিয়ে যদি কাজ করি, এর থেকে বড় সম্মান দেখেন আর কিছুতেই হতে পারে না। আজকে today in this ECG study group online course, ECG Basic and Beyond, we should take a resolution that we should devote ourselves to improve ourselves, to improve the cardiology as a whole, the whole aspect. And through our action, through our devotion, we are going to pay the utmost respect to our father of nation. Thank you, everybody. And today, Professor M.G. Azam is going to talk about non-STEMI. I'm requesting Professor Adhar Ali sir to tell a few words about Professor M.G. Azam.
Good evening. Thank you very much, Professor Abdulwahid Chaudhary. It is I'm very much happy to say something about Professor M.G. Azam. Actually, everybody knows in this forum Professor M.G. Azam. At this time, he is one of the most brilliant, talented, and dynamic cardiologist, interventional cardiologist, clinician, as well as academic teacher in this country, Professor M.G. Azam. He is busy with many of the organizations and societies. As for example, he is a scientific secretary of the Bangladesh Society of Cardiovascular Intervention, and from that forum, he is leading that society in a dynamic way. He has organized several workshops and international activities. He is also a publication secretary of the Bangladesh Cardiac Society. He is also the course director of the total occlusion, that is the TOBI, total occlusion of the TOBI. I see Professor M.G. Azam will clear it. That is the TOBI, that is total occlusion of the cardiovascular. And he is also the course director of the Bangladesh Academy of the Cardiovascular Therapeutics. Like this, he has also busy with many other dynamic activities, forum, and the teaching forums like this. He is a very much a popular teacher, and his lecture is always enjoyable. I am very much eagerly waiting to hear from Professor M.G. Azam. So this is Professor M.G. Azam, today's speaker. I like to welcome Professor M.G. Azam to present his cases. That is the Professor M.G. Azam.
Azam, unmute, please.
Am I audible, sir?
Yeah, now audible. You can start screen sharing.
Okay, sir.
Azam, now we can see you, see your slide very nicely.
Anyway, sir, am I audible, sir? No?
Yes,
sir.
quite nice.
Professor Atali, sir, for your kind words. And I am really happy and really honored to be here. Very prestigious organization like ECG Study Group, Basic and Beyond. And I must give special thanks to the course director, Professor Abdulwadud Chaudhary, sir, as well as Professor Atali, sir, and international course director, Dr. Rafiquddin, sir, and Chaudhary Hafiz Ahmed Chaudhary. And I must give special thanks to the national and international faculties and all of our fellows. Very good evening. As it is said by Dr. Tushar, it is STMI, non-STMI lecture. Actually, rather I have to say it is a discussion. So I think it will be much more be healthy if we make it discussion. So before going to my presentation, my slide is not moving. Yes. Okay. Before going to my talk, I just tell you one story. I think everybody you know, Dr. Watson and Mr. Holmes, both are very good friends. They went one fine morning, day-long program for hunting in the forest. After hunting, they become tired and they put a tent in the woods. At the middle of the night, Dr. Watson, amazed to see the full moon in the sky. Then he insists to show Mr. Holmes, look at the sky and you should enjoy the beautiful moon. At that time, Holmes replied, yes, I see the beautiful moon, but I am thinking who stolen the tent. So dear friends and colleagues, today's my role is to show you the moon and your role with the faculties to find out the tents. So this is my aim and objectives of this today's session to identify common ECG pattern in non-STEMI, mostly focused on those in which it occurs mostly and some critical ECG scenarios in our real life practice. And we hope after the discussion, we can able to understand what and why should we know and how should we manage our cases. Let's see our case number one. 40 years, fair, hypertensive lady, non-diabetic, attend emergency department for 3 hours of ischemic type of chest pain. Our initial troponin was 1.83 nanogram per ml. His emergency department blood pressure according 130/80. She was on beta blocker and ACE inhibitor. And this is her ECG. If you look at this ECG on the top of his background, my first question to our fellows, what is the heart score of this patient? As you know, heart score is very important tool to assess emergency settings to either you go give the admission or not to admission, or what is the risk of this patient, either you go for invasive studies or not invasive studies. Then if you look at this, if you look at the ECG very critically, if you look at this ECG, emergency department ECG, what does the ECG shows? If I tell you what is predisposed depression, ST elevation in AVR and V1, anterior T inversion, left axis deviation, and above all, I think we should go into poll. Ribu, can you go to poll?
Yes, sir. Starting the poll. Sir, will we keep it for 30 seconds?
Yes, 30 seconds.
Okay.
I think that is perfect. I am requesting Professor Abdul Wadud Chaudhary sir. Would you like to make any comments sir, regarding this ECG?
As you have mentioned, the key points, there is widespread ST depression and along with ST elevation in AVR and V1. So that suggests it's either left main or very proximal LAD. If the depression is 8 out of 12 leads, lead zone, then it's more likely left main. ST elevation in V1, if it was not present, then it would have been more likely left main. If it is present, it's more likely proximal LAD. But as a whole, this patient is in bad shape. You have to admit the patient.
Sir, that's great, sir. That's great, sir. Your message absolutely, sir, amazing. And actually, in our case, this case, our heart score, actually, what should we do? Or what is your next step? If I ask our fellows, if I again go into the pool, whether we should go for fibrinolytics as ST elevation in AVR and V1, and whether we should go for SCPT or DAPT, or we should go for anticoagulation like heparin or unfractured heparin, or we should go for early invasive strategy. Ribu, you can go to pool.
Yes, sir. Starting, sir.
Huh?
That is perfect. We should consider early invasive strategy as nicely said, Professor Abdul Wadud Chaudhary sir. Dr. Professor Hafiz Chaudhary H. Hafiz, sir, are you there? Are you here, sir? Professor Hafiz?
Acha, MG Azam, Professor.
Sir, Athari sir, bolen sir.
Yes. Yes, I also requesting Professor Hafiz Chaudhary, please. Just if you were in the forum, please answer. Now, my question to Professor MG Azam.
Sir.
If this patient is in Feni, you think the
In?
patient might be in the Dhaka city or this patient may be in Feni General Hospital?
No, this is in
That's
Dhaka
what-
city. This
No,
is
no,
in
no, no, no,
Dhaka
no.
city.
No. My question is that if I face this patient in Feni General Hospital, what
Right.
should be my approach?
Yes.
Right, sir.
Good, sir. Okay, sir. I will give you the answer. If it is in Feni city, then what should we think actually? This is our motto to discuss here. It is, if you look at the critical ECG, this is AVR, ST elevation, and V1 as well as what is ST depression. It should be considered as STMI equivalent case. It is STMI equivalent. It is not STEMI. As we know, if contiguous two leader ST elevation, that it should be considered ST elevation MI, then we should take decision, go for lytics or primary PCI, whatever you like in your facilities. In case of FENIS, if ST elevation MI, you can give lytics. But in that case, in FENIS city, it should be considered as STMI equivalent case. That makes sense. It should be treated aggressively and early invasive strategy, as because if you go for early invasive strategy, you can reduce morbidity and mortality as well. And how you can start? In that particular case, we don't prefer fibrinolytics. Of course, we should start DAPT. Of course, we should go for heparin, whatever you like, as well as early invasive strategy. These B, C, D are correct answer. In Feni city, if you don't have the facilities, you at least start DAPT as well as heparin or unfractionated heparin. Then you stabilize the patient. Then you send it to your next center immediately as soon as possible. So that is the Feni city. If you consider the Feni city, that you can approach like that way. If we look at this, our case, this
Any
heart,
question, please, Dr. Azam.
right? Sorry.
May I ask please, about the blood pressure of this particular patient?
Yeah.
Blood pressure.
Blood
BP. Blood pressure of this
This patient blood pressure was 130/80.
80. Okay. And if it is left main myocardial infarction, why not fibrinolytics? Why we wouldn't be able to give fibrinolytics?
Right. Dr.
I
Shafiq,
can.
I appreciate your answer. I understand your question. As I understand, you are considering it is STMI. As I said you, it is
Right.
STMI equivalent. You know, in 2017, ESC recommend to give lytics or primary PCI strategy. In 2020, it is not recommended. It is recommended for a high-risk invasive strategy. If contiguous two lead ST elevation you found, you know, AVR and V1 is not contiguous. Contiguous means the same region if two lead. It necessarily not means lead 1 and lead 2 or one lead 5 or lead 6 or one AVL also contiguous lead. If two contiguous lead ST elevation, then you should classically say it is ST elevation MI, then you can consider lytics or primary PCI, whatever you like, what facilities you have. In that particular case, we give emphasis to our fellows or our emergency physicians or the doctors who are working in CCU that take it into account. It is left main equivalent. It may predict
At least one.
or multivessel disease, but it is not specific. That's why we go for early invasive strategy.
Right. May I add 2 points? In 2 cases where there is a ST depression, that is in left main type widespread ST depression and posterior MI where there is ST depression. And these 2 cases, we can give fibrinolytics.
Yes, I show you the case, and anything can anyone can add anything. If not, then I can proceed.
As usual,
And I have one point here, because that's for the fellows and all the doctors who are treating the patient on the ground. কারণ জিনিসটা হচ্ছে কি আপনি যে চয়েস গুলো দিয়েছেন fibrinolytics, SAPD, DAPT, heparin,
Aziz Bhai, there are students who are from Nepal, so we have to speak in English.
Sure. So yes, I'd like to definitely talk to you in English. The reason is that the choices are given A, B, C, D. I think the first thing, probably the right answer should be heparin. You have to start anticoagulation. You have to start a DAPT the next day. First given aspirin and then heparin, and then you can start either the P2Y12 inhibitor. I think the best answer in this case, I believe happened. The first thing you need to do, yes, early invasive strategies is necessary, but the best answer would be C.
Best answer.
Because that's the first thing you can do immediately right then in the emergency room, first thing. And then you send to the cath lab. Yes, he's a high-risk patient. If you can, if it's available to cath lab. But in rural situation, the discussion, I'm listening to you, how you're describing that.
I appreciate your answer, Aziz bhai, because in any setting, we should, once you diagnose non-STEMI, our primary target to anticoagulation or start antithrombotic treatment, antiplatelet as well as anticoagulant as soon as possible, whatever your strategy. So I accept B, C, D answer. But regarding this particular case, definitely we start DAPT and anticoagulation, antithrombotic. I just show you the slide. But you should give the awareness to our fellows to make sure you should go for early invasive strategy. If
that is correct.
Azam, can I add something?
Sure.
In our country, it's a problem that you cannot get unfractionated heparin in the rural setting, but you can get low molecular heparin. Enoxaparin is widely available. So
I show you slides.
So you should pay some attention to the instruct the fellows what to do, what heparin to use.
Right, sir. Just next slide. Okay, sir. This is the heart score. Actually, I just bring it here because in emergency setting, at least variables you should know how to score in this system, not necessary to remember or memorize. You just go to a smartphone, you just give the variables that will give you the score. So don't bother. You don't remember to all of the variables. You just know how to make heart score. Is in our case, this heart score found from the history, ECG, age, risk factor, and troponin that is found, it is around 7. That means it is a high risk group, 72% chance of mortality within 6 years. It is a very high risk group. So if we move next slide, regarding Professor Dr. Shafiq, just asking why you don't give the fibrinolytic therapy. As you see, intravenous fibrinolytic therapy not indicated in patient without acute ST segment elevation MI or true posterior MI or presumed new LVB. But in unstable angina or non-STEMI, we never give lytics, rather it is harmful. So I move the next slide according to to answer the Professor Abdul Wadud Chaudhary sir and also Aziz sir. We should start actually as soon as possible. Our main target, antithrombotic treatment, we should start as soon as possible in hospitalization, loading dose and continuous dose, preferably aspirin, as well as P2Y2 inhibitor, clopidogrel, or whatever you combination like, and unfortunately heparin or fondaparinux, and you also enoxaparin. It is very easy to dispense. That's why we usually in Bangladesh we prefer enoxaparin in our practice. Almost 99.99% center used enoxaparin in our settings. And one other message I want to give you, if you go for PCI or don't go for PCI or don't go for invasive strategy, you should discharge the patient with DAPT at least 12 months, whatever the procedure status. And if before, and I see all of the fellows are answered very nicely, invasive strategy should give the priority. Before going to invasive strategy, let me ask a question to our fellows. Again, we go to the poll. How much coronary arterial severely disease, if in case of MI, less than 50% coronary artery stenosis, most of the cases are 50 to 70%, or more than 70% stenosis, or 100% occlusion in case of MI cases. Ribu, can you go to poll?
Yes, sir. The poll has been started.
I think this poll is 20 seconds is enough.
I guess, sir, because many participants are answering.
So, Professor Azam,
yes,
nicely told everything about the management non-STEMI, but you are not giving the patient statins. Why have you missed the statin, either intentionally or?
No. Statin, it is conventional management is there. I think this is not a.
The fellows, they
At
have
the
to know about
end of the session, I conclude regarding beta blocker, ACE inhibitor, whatever you like. I just make the discussion more interactive way so that they can raise their questions so that we can interpret or answer as well.
Professor Azam. Hello, Azam.
Sir.
It's a nice distribution of the answers, C and D dominating. But one question, from before this discussion, is it possible to have a MI in a already 100% occluded relations? Is it possible?
Sir, as
good question.
you know, myocardial infarction. As you know, myocardial infarction doesn't miss always non-STEMI. It also ST elevation MI also. So in that particular situation, when STMI, it is assumed there may be total occlusion. So it may happen. But in case of non-STMI, it is, if you look at the pathophysiology, it is actually partially occlusion of the coronary arteries. So it is not necessarily 100% occlusion need to occlude the coronary artery, present as a coronary artery disease. So if I go to this answer, most of the MI, if you go for coronary angiogram, what we find actually in our clinical practice and what evidence we have in our hand. If you look at these 4 studies, Ambrose, Little, and Novosis, and Giroud, all studies showed less than 50% lesion, around 68% cases. Only 18% cases you can find 50 to 70% stenosis. Only 14% you can find more than 14% or 70%, more than 70% you can find 14% cases. So I think this is our message to our fellows. Not necessarily more than 70% stenosis is required to diagnosis. It is MI. So most of the case, less than 50% stenosis may present as MI. Whatever you can say, it is ST elevation or non-ST elevation MI. So, sir, anyone can add anything or any comment from particular point, sir?
Yes, I'd like to make some comments on that. The reason that is correct, less than 50% the most, if you include all MIs, because it's why it is important. It's important to risk stratify those patients and how to manage those patients to prevention. That's why it's important that even if a 40-50% blockage, if you treat them with statin therapy, if you ask them to exercise, what it does, if you have plaque, there's a cover on top of the plaque. It can make the plaque membrane, plaque cover more stable, more thicker, so it doesn't break. And also inside the plaque, there's always inflammation going on, a different kind of metalloproteinase, different kind of inflammatory things happening inside the plaque, ultimately brewing ruptures. That's what you need to prevent those. That's a statin medication. We call it pleiotropic effect of the statin, anti-inflammatory effect of the statin, not only lowering the cholesterol. That's very important. Exercise and good control of the cholesterol, LDL below 70, is extremely important to prevent those infarction. Because it's happening, you're right, less than 50% most commonly in all of the MIs if you include it.
Okay, thank you. So what
Can I
we
add
do
something?
in our case? Sorry,
Can I
sir?
add something?
Sure, sir.
Actually, that's the reason. That's the finding actually that lead to the extensive investigation and the concept of vulnerable plaque. Actually, the plaque, when it is around 90% or calcified, these are rather stable plaque. They won't get blocked due to rupture. They are mostly due to thrombotic episodes. But when it is 40, 50, 60, these are vulnerable plaques. They often rupture and just pull out the very thrombogenic material inside the plaque. And that give rise to instant thrombosis locally. If it blocks totally, then we get a ST elevated MI mostly, or we can get non-STMI. If the fibrinolytic system, in our own fibrinolytic system is very active, we can get non-STMI because some flow is still there.
But Wadud, may I make a comment?
Sir, please.
So long been, we have been fooled in cardiology because we have put the cart before the horse, I call it. And the reason I'm saying this, because how to look for this plaque? Because we are obsessed with the stress testing, right? If the question is wrong, the answer is wrong. The question is not, we have coronary artery disease, we have coronary plaque. Our question is, we have a hemodynamically significant coronary disease or not. Then you can do stress testing and so forth. But if the question is how we detect this plaque to figure out, from public health point of view or from individual point of view, how you can find out this less than 50% block, right? So whether we have the disease, the oncologist, I call it carcinoma in situ and then staging. In oncology, they don't go for the Bayes theorem and then Forrester classification. They go for biopsy. So now if you look at the ESC new paper, right? And then NICE guidelines 2016, they said, okay, you can do CT angio. But CT angio cannot give vulnerable plaque, but it can detect at least atherosclerosis in the coronary disease. Now I would request everybody to look at Dr. Narula's paper, 2021, from the Society of Coronary CT, that at least we are now getting guidelines that, yes, you can do CT angio as the first line investigation to detect coronary artery disease. Does it mean anything? No, because CT angio cannot be specific in terms of defining the absolute stenosis, but the specificity as a negative predictive value, CT angio is a very good tool. So bottom line is that we need to ask ourselves, what is the question? Is it a highly vulnerable patient? And it makes all this sense to be aggressive in terms of risk factors. If you want to know more, does the patient has atherosclerosis? A stress test may not be the right answer. If you are exploring what is the cause of the chest pain in the setting of stable coronary syndrome, chest pain evaluation, you can do stress testing. But in the patient in the ER, remember, heart score goes out of the window. And it was 2008 publications. That was only patients who come to the ER with chest pain syndrome where you are equivocal. If the patient has ST elevation, crashing, burning, shock, those are excluded. And the patients with the dynamic ST changes and severe chest pain, and then troponin already positive, is beyond heart score now. But I don't know about the faculty, maybe we will be divided, but we all agree about the heparin, and that's not the issue. Issue is this: what is the principle of therapy in terms of AVR ST elevation and ST depression? Is it, we'll call it a ST elevation MI and thrombolytics if PCI not available? If PCI is available, it's easy. It's easy, right? But if the PCI is not available, will you consider this ST elevation MI and give lytics? I think that was the question. I don't know why Atharvai chose Feni Hospital, but here we are. What will be the faculty's response?
I would choose it as like a ST elevated MI.
No, actually,
Hafiz bhai, I put this issue here. We should find out it is STMI equivalent. It is not STMI, classical, not STMI. I already explained it. In that particular situation, it is on the top of non-STMI. We should go for antithrombotic strategy as soon as possible. Whenever you stay in Dhaka or Feni or Nilphamari, whatever you say, you start antithrombotic therapy, antiplatelet.
Agreed. I'm saying that, will you give lytics? That's my question.
No lytics. I show a slide. It's because there is, it is 2017 recommended, sir. 2017 AC recommended to give lytics, but 2020 recommendation.
It was my question as well.
Professor Azam, can you back to the ECG again, please?
Sure, sir.
Chaudhary Hassan, actually for ourselves and for our participant, it is very much essential to define whether we should call it ST elevated MI or ST depressed, that is a non-STMI. As because there is a clean cut ST elevation in AVR and V1. Professor Azam's defined, unless there is contiguous lead, it should not be called as the ST elevated MI. And if it is not the ST elevated MI, we cannot give the fibrinolysis. Now question is, what should be the labeling of this patient? ST elevated or non-ST elevated? This is the first thing for our participant. This is the forum we should a clear answer to this question.
Forum should take the message. It should not be considered as ST elevation MI, classical ST elevation MI. It should be, if you consider, you can consider it is STMI equivalent. It means you give aggressive treatment strategy.
Now, Azam, that's not the question. The question is, it's not STMI, everybody accepting that. It's STMI equivalent, everybody accepting that. But if you don't have PCI, are you going for fibrinolytic? That is the question.
No fibrinolytic, we go for antithrombotic strategy, sir. Sir, you go for
you are going for aggressive heparinization, anticoagulation.
And antiplatelet and anticoagulation, sir.
Yeah.
I think this
Azam,
I think this
Arun, your input, please. Professor Arun.
Arun Maski, please. Arun Maski.
Yeah, I think
you have noticed that very conveniently I put the question in and then I'm just in the sideline because I think the faculty will be divided on this issue and I'm kind of enjoying this.
No, if you look at this, if you look at this,
one thing I want to say this.
Jamil, Arun Maski first, please. Arun Maski.
Okay.
Arun Maski,
so what is important is not treating ECG. That's first point. If you look at this NSTEMI 2020 guidelines, what it says is divide patient into 3 categories: very high risk, and low risk. If you're thinking patient in low risk, avoid it. When you are given an ECG where there's the ST depression in more than 6 leads, ST elevation AVR and V1 is a very high risk category, 1. And then you have to look for clinical context. If the patient has a hemodynamic instability, patient has a chest pain despite refractory angina despite maximum medical therapy, if the patient presents with heart failure, if the patient has mechanical complications, and these are the points where you should treat patients clinically, whether this patient is in periphery or center. And the current recommendation is the NSTEMI recommendation has changed. If you think this patient has very high risk group patients, this patient needs invasive strategy within 2 hours. Just because if you diagnose this patient with NSTEMI, then this patients by ESC guideline, you have to do angiogram or invasive treatment within 24 hours. So clinical context is very, very important in these patients. Like you have given a context, if the patient is presenting with acute heart failure, there's no question of giving a DAPT and treating with low molecular weight heparin. You should think that the best treatment is doing invasive therapy. So very high risk categories are more dangerous. So you have to treat patients within 2 hours. So this is an important message in this disease, I think.
Dr. Arunmaski, let me comment one very important point here. For the STEMI, we all agreed what to do. For the non-STEMI, high risk, within 2 hours, crash and burn, we all, and last weekend we discussed this. The issue is, I want to make it categorically clear that even if it is high risk, but you are dealing with non-STEMI, there is no role for lytics in those groups.
Yeah, that's true.
We need to be very clear about it. That even in the high risk group, crash and burn or shock, please do not give lytics. Question is, in a very crash and burn, but it's STEMI, you give lytics, right? When there is no choice. So because the patient is very sick, does not mean we need to give lytics. Having said that, my question to the faculty again, if it is ST elevation in AVR and the patient is in front of you, there is no cath lab, what I just want you to know, and I'll tell you, there is no right and wrong answer yet on this issue. When you are constrained with the resources, what is the best answer? Will you give the lytics or will you give antiplatelets, in dual antiplatelet, anticoagulation, and hope and pray and go to the invasive strategy. That's for sure. We all agree for that. But when you have nothing available, will you give lytics?
My answer
Will
is
you
no.
consider this STEMI pathophysiologically? That's my question.
No lytics. That's what I think.
Let me make a comment on that.
I just tell you, we should not give lytics because non-STEMI pathophysiology, it is not total occlusion. It is white thrombus, partial occlusion. There is a thin fibrous cape. If you give lytics, that may disrupt the thin fibrous capsule, and that may extend into the total lumen. Then aggressive complication may happen. Total occlusion may precipitate it. On the top of, there is a more chance of bleeding complications. So
I like to differ some in some point, Azam, with you. In case of if it is total occlusion of the left main, then you are not getting any time to have ST elevation. So it will simulate like non-ST elevation. And if you consider that it's not totally occluded, it is partially occluded, then it is going to be a disaster. And what I was trying to say at that time, that if we follow the guideline, as it is non-ST elevation, so even primary PCI is also not indicated here. But guideline is guideline. You have to individualize a patient. And if you suspect it's left main occlusion, there is no time. The patient is not going to give you time. And this kind of patient usually die very quickly, and it is early invasive can save the patient.
Thank you, sir. Now I should move.
Basically, in any patient with total occlusion of the left main disease, you find him presenting to you in the emergency department or in the cath lab, or he died in the pathway to the hospital.
I think after
occlusion of the left main,
some patient reaches the ER and comes to
Azam,
the
please go ahead with your presentation because we are getting late.
Azam, just a minute, please. I like to request Professor Abdul Wadud Chaudhary, after a healthy discussion for our participant from this ECG, you just put a message. What should be the message to our participants? Because this is a good discussion, but still the participants are confused. What should be the final message from this ECG for our participants?
I will tell you something.
আমরা মনে হয়েছে আরো 2-3টা কেস আছে আমি দেখালে তারপর ইজি হবে
Azam, please go ahead with your seal. We will talk about it later on, but we are getting late.
What we go for early invasive strategy, and we find left main ostial 70% lesion, critical lesion, and mediality around 90% lesion. L6 also total 99%. RC also significant is left main triple vessel disease. What is my message to my fellows and my colleagues? As you know, as we already observed the ECG, ST elevation AVR more than 1 millimeter than V1, and what is pressure depression. It gives you a sense most likely left main disease may involve, but messages to my fellows, it is not 100% specific. That should be very clear message you should keep in your mind. Number one. Number two, actually, then what we advocate early invasive strategy to make sure what other condition like pulmonary thromboembolism or LVH with strain, or about or you may consider aortic dissection may also present there. So you should don't go lytics, please. You straight away go for antithrombotic strategy as soon as possible. Then best management, best sedation, whatever you can say, statin. Then if you have the facilities, you can transfer to nearby center. I give you some question next slide. Okay, I think I should move the next case actually. Okay, this is a second case, 50 years male, diabetic, smoker, not hypertensive, previous history of ischemic stroke, and attended emergency department 4 hours with chest pain, ischemic type of chest pain with sweating and vomiting. Hemodynamically unstable, and his blood pressure was 80/50, and his troponin 16 nanogram per ml, and ECG shows, sorry, this is the ECG, not too much serious or very complicated ECG, I think, and his heart score actually in emergency department done, that is around 7. And if you critically evaluate the ECG, what findings you have, what does the ECG shows? If I go to the pool, same What is ST depression or ST elevation AVR V1 or left axis deviation or anterior T wave inversion or above all. I just go to the pool.
Sir, I've started the poll.
So any comment from our faculty, sir, from this regarding the ECG and the school result? Most of the answer E, and second is C. Atharali, sir, this is not significant, very serious ECG. Don't take it serious. You should see this. It gives you some clue on the top of the ECG patient presentations.
Tough competition between C and E.
Anyway, sir, we accept anterior T inversion, left axis deviation, whatever the answer, but our primary motto to make the session healthy for discussion. If I go to the next slide, actually, what should I do? This is hemodynamically unstable, as Arun Maski nicely said. Patient hemodynamically unstable with few ECG change. If more than 10%, more than 6 lead, that may also give poor prognosis and clinically diagnosed non-STEMI with features of hypotension. So we should go for early invasive strategy, no doubt. Before that, we should go for heart score, TMRC score, GRACE score, whatever the score. As because ESC 2020 guideline, if you look, that should be recommended early invasive strategy. So accordingly, we did invasive strategy versus as it is already explained by Dr. Arun Maski, hemodynamically unstable, recurrent refractory chest pain, life-threatening arrhythmias, mechanical complication or acute heart failure, non-stasis, ST segment depression, 1 millimeter more than 6 lead, or diagnosis or dynamic ECG changes. Then we should consider early invasive strategy. But if what we did in our case, actually, if you look at this angiogram, so what is the findings? I think Arun Maski, can you show the can you see the angiographic pictures?
Well, I mean, this is a still pictures.
Right, this is still picture.
So based on that proximal LED, I can see some lesion in moderate to severe stenosis in the lesions. I'm not very sure whether that's thrombus or just plaque. Very difficult to comment on this still pictures.
Are you in laptop or mobile?
I'm in the laptop.
So I think you can say, okay, fine. Actually, there are multiple radiolucent areas there.
Yeah.
So look at this here, so that I think now you can interpret it here because you have.
Yeah, I can see that, but until and unless it's a moving pictures, because we need to find whether it's a diastole or systole.
Yeah,
so
yeah.
Still pictures are very difficult to find in these patients. Yeah,
Okay,
and looking at it, I just can make it. The third image, maybe it's tight in ileocaudal view. Other views, it's just in first view also, it looks like 70%, but not sure whether this is thrombus, a plaque, very difficult to comment, but looks moderate to severe stenosis.
Okay. So if I then it is actually spontaneous coronary resection, SCAD. So we fix it. Then we fix it. Actually, as because that is hemodynamically unstable, we just go to the immediate cath lab and fix it. And this is the management algorithm for SCAD. I don't go in details. I think everybody can go to the ESC guideline. Then he can find how to manage this case, especially type 1. In our case, that is type 1. That's why we manage by PCI as it is feasible. Then I move our next case, because already we take more time in first case. That's why I have to show one more case. That is 55 years male, hypertensive smoker, non-diabetic, but history of dyslipidemia and chest pain for 10 hours present at emergency department. His troponin was 22 nanogram per ml and his blood pressure was 160/70 millimeter and he was on beta blocker and ARB. This is his ECG and his heart score also almost 8 and it is also high risk. Then if you look at the ECG, what are the findings? If I go to the pool and then similarly widespread depression and Q wave in 2-3 ABF and violent type ECG and next true posterior MI or above all or frequent PVC. Anyway, Ribu, can you go to the poll?
Yes, sir. I've started the poll.
Am I crossing my limit or I think it is 30 minutes more? Other sir?
10:30, na? Do you have
আমি কি স্যার বেশি সময় নিয়ে নিচ্ছি স্যার?
no, actually it is a good discussion, so সময় তো লাগবে। আর কয়টা, how many ECG do you have?
না আমার স্যার আর 4টা কেস আর দুটো জাস্ট দুটো শো ইসিজি স্যার কিছু আর 3-4টা কোশ্চেন আর কি শিখলো আর কি স্যার আমরা কি আলোচনা করলাম?
Excellent. I think you can you try to finish it in 5 to 10 minutes.
Next ECG, okay sir. I can try.
See.
So I think it should be appreciated. Well, it is all in type ECG. Okay, fine. Next move. What actually?
No.
Sir, sorry. Okay. So any comments sir, from the panel? Professor Hafiz.
So yeah, I agree that this is it can be, some will call it like Wallen's type B, rather than the typical biphase equivalence 1. But I wanted to tell you one thing, that the AVR ST elevation and ST depression, most of us will consider this, yes, this actually not STEMI and not give lytics. There was actually a study on this from Arizona, and they looked at this. Only 10% had acute left main occlusion, because most of them are partial occlusion and then and significant EKG changes. Why this is an important issue? Because if you look at the early TIMI-3 trials, where partial occlusion and giving lytics actually was more harmful. So not because the patient is very sick or hemodynamically unstable and no choice, I would intensify the anticoagulation and dual antiplatelet rather than giving lytics and transfer for, as Dr. Arun Maski said, that early invasive therapy, ideally, if you can do it as quickly as possible. And ESC guidelines, which is, by the way, is one of the best guidelines so far, because USA is behind on the guidelines on non-STEMI. ESC has taken over on this. So that's my comment on this. About this EKG, I would caution one other thing, Azam, for the frontliners, that if the patient is in cardiogenic shock, then the GRACE score, TIMIDIS score, they don't work, because those are not the patients that they included in the study. And heart score is a good tool, but if you are thinking about intermediate group, if it is a high risk TIMI, then please don't try to use the heart score. So I usually tell the ER, if you are thinking about admitting for high risk, then don't worry, admit. But if you're thinking about borderline and then discharge, then heart score actually very powerful too. Anyway, that's my comment about this patient.
I appreciate this comment regarding heart score. Actually, I put it here to make sense.
Yeah.
In emergency department, how you make decision is because some of patients attend our emergency department. You see, oh, it is not too much serious. You discharge, and on the other end, on the roadside, then he died. So there are a lot of catastrophe occurred in our emergency department.
Absolutely.
So I try to aware our emergency department physicians as well as CSV physicians how to make your decision actually, when you admit and how you discharge in the following day, second day. If it is low risk, less than 3, you just discharge it patient. No, without any hesitation.
And that actually shown that it's a very powerful tool that way.
Right. Anyway, sir, next I move this case. Actually, everybody answered very nicely. And actually, this voluntary B ECG, and what is the importance of this ECG? Actually, it is also one of the STMI equivalent. That is, as I said you earlier, it is ABR and B1. It is also de-inter and well and also considered to be it is STMI equivalent. If you treat it early, you can save, you can reduce mortality and morbidity. As you see, you go angiography, LED total occlusion around 99%, 100% occlusion. Then we fix it up and we put the all medications and then discharge patient. Fine. This is my final case. And 65 years male, hypertensive, non-diabetic, history of chest pain. Before going to my, this is a typical case. That's why I just make some comments regarding my first 3 cases. Actually, what we learned from this, our 3 cases. These are the STMI equivalent on the top of non-STMI diagnosis. Very high risk non-STMI case. We should treat it very aggressively, no doubt. But we should remember that an ECG is not 100% sensitive for coronary occlusion. This is my take-home message. We should remember that an ECG is not 100% sensitive for coronary occlusion. And that the absence of STMI, especially ST elevation, which Dr. Hafiz tried to say, does not rule out any myocardial infarction. I think these 3 cases are very excellent case of patient recurring PCI, even though their ECG didn't meet STMI criteria. So we did early invasive strategy and we go to the cath lab and we reverse as well. We should remember that you are treating the patient in front of you, not the ECG. So serial ECG are always recommended and appreciated. It acts as your friend, best friend. So you should prefer to do as much as possible for serial ECG so that your decision will be much more clear. So now our final case, that is 65 years male, hypertension, non-diabetic, history of chest pain with 3 hours, attend emergency department 1 month back in our hospital, diagnosed as unstable angina, managed conservatively, but after 1 month again came with syncope with progressive chest pain in our hospital, and his troponin found 6.58 nanogram per ml, patient on AC inhibitor. If you look at the first ECG 1 month before, what does the ECG shows? If you go to the pool review, you can ready the pool so that our fellows can see the ECG and I can give the options. RBV, bifascicular block, trifascicular block, complete heart block, or LVV. For the pool, I can see the ECG.
এবং আমাদের যে অবদান এই সমাজের প্রতি আমাদের যে অবদান এই অবদানের কি
B and C bivesicular block.
B and C. I think we should accept the result. Atrali sir, are you agree with sir this result?
Yes, I agree. That is excellent.
We should accept the result as because it is bifascicular block with in the RBV setting, first degree heart block or left atrial deviation. You can say trifascicular or whatever. We accept this result. Okay, we can go for the next. We should accept anyone can be volunteered to make any comment. This is patient attend our hospital, chest pain. This recent admission was due to non-STMI. Previous admission was due to unstable angina. This is previous ECG. Ischemic type of chest pain in the setting of this ECG. So after 1 month, he attend again our hospital with this ECG. So again, we go to the pool. It is 2:1 block or 3:1 block or trifascicular block, or complete heart block, or very high grade AV block. Sir, Rafik sir ki sir আসছে sir, Rafik sir
না রফিক স্যার এখনো ঢুকে নেই আজম।
sir গাড়িতে না। Remove, what is the pool result? I think it's perfect, sir. Do you accept the result, sir? Or any comment from any panel from our senior?
Perfect.
Yes, answer is acceptable,
doubt.
but
I think this is a study group, they work very nicely.
but still there are few to just answer as the trifascicular block, and they need to be clear about the difference between the trifascicular block and the complete heart block.
Sir, sometimes patient, someone may misplace their finger. Sometimes it may happen.
Why not complete heart block here?
It's complete heart block.
As because there is a AV dissociation, RR interval almost regular and PP or almost regular, and
Majority answer
ventricular rate around 30. So why not complete heart block?
majority open complete heart block.
Govindo, this is right answer is the complete heart block.
Yes, sir. I'm agree with you, sir.
Dr. Govindo, most of the people answers the complete heart block, right, sir?
Right.
Yes, yes.
Dr. Azam, do you want to comment on the T-wave changes in the chest lead?
Nah, Dr.
You
Govindo
want
is
to
saying
some comments on the T-wave changes in the chest lead. Patient has got history of the chest pain, ischemic type of central chest pain. Last ECG showing a bit hyperacute T, and this is the second ECG. Why there is conduction system abnormalities as well as some T changes.
First ECG,
In the chest lead.
Dr. Govindo, what is your comment? It is complete heart block. Do you agree?
Yes, yes, complete heart block.
Dr. Khalikujaman, what is your question? Actually, I can got your point.
Khalikujaman, sir.
I was giving attention to the changes in the T waves in the chest lead. These are the biphasic T waves as well.
T wave.
T.
This ECG, Khalik.
This is the T wave change. Biphasic T waves.
Achha.
Initial negative inscription followed by positive.
B4, 5, 6, right?
Even the V2, V3.
If you consider the R wave, T wave is tall T wave here.
Khalikujaman, the atrial rate is more than 100, and some of the P waves are actually, the T waves are most of the time they're distorted because of the P wave, superimposed P waves.
Might be.
Let me comment on that. Actually, it's very clear. The biphasic T wave that you're seeing, that's basically the P wave on the T wave. That's you're seeing. Because look at that P wave, they're marching together, exactly the same distance. They're more than the V wave. And the PR interval definitely different each time. There's no correlations. It's complete heart block. And the T wave, you're looking at the biphasic because the P wave, you can see some notches there. And you can put the caliper, you can see the exact distance between the P waves, hence falling into the T waves.
True.
So can we move next, sir?
So I will request you to finish your cases because
almost finished, sir. Almost just finished.
Okay.
This is actually what we did. Patient now on TPM, and yesterday we just go for PPM implantation. Before PPM implantation, we just take a shot. We find only osteal RCA 50, barely you can say 50, non-dominant 50 to 60% lesion after giving nitrates. It is not significant. Then we make decision we go for permanent pacemaker, as well as we should keep on antiplatelet statin as well. And this is our case.
You did not put any stent, right?
No stent is there.
Absolutely brilliant decision.
No put, because only we put, though it is not ethical, we put a
This was a red herring. This was a red herring.
This is single chamber pacemaker which is supplied by government. We did it yesterday, and just I'm very close to my slides. What should we remember? Mimics are common. Our target not to miss STMI, as emphasis given by Professor Chaudhry's office, or high risk non-STMI, as emphasis given by Dr. Aziz as well as Dr. Wadud sir and Dr. Arun Maski. So our emphasis, our target not to miss STMI or high risk non-STMI. If I just show you the two ECGs, but just sample. If look at this ECG, any one of the fellows, anyone can be participant, or any one of the faculties can interpret this ECG. This ECG nicely tackled by my student, and I think anyone can be volunteered to read this ECG. And what is the importance? What should you do for next step? Atharali sir, I mean, sir.
Basically, the ST segment depression that is confined within the V1 to V3.
Right.
Other leads are normal. So you have to, next step, you have to do the posterior leads, so posterior lateral.
Excellent.
Lateral MI.
So
my L6 territory.
So we did accordingly, and my fellows did nicely. Posterior lead, you see, this is elevation in V7, 8, and 9. That is posterior MI. So what is the message? And I just give the similar ECG to stimulate our young chap brains. It's similar. It is T inversion, not T upright, ST depression as well, and up to B4. But it also go, if you go to posterior lead, that is also posterior MI. So my message is very clear. My message is to, if you get any ST depression in the precordial lead, you must not, you must be not sure that there is non-STMI on the top of chest pain and troponin. You have to go for posterior lead, as because sometimes you may get precordial lead V1 to V3 or V1 to V6, or sometimes similarly you can find ST elevation in inferior lead that makes you sense very easy clue to diagnose extension of the posterior MI. But when don't involve in posterior inferior MI, that makes some problem to diagnose it is a true posterior MI or not. So you have to go for posterior lead to make sure, as because true posterior MI, isolated true posterior MI around 5% case we can find. So you can address, if you posterior MI, you can give lytics or primary PCA as well. So it is very important message to my fellows. If you find any ST depression from V1 to V3, you must go for posterior lead. And this is as you know, this is a pathophysiology ECG. And sir, I just read the three questions, what we understand actually. And ECG risk assessment, I don't know details. I just go to the straight away question. Sir, can I allow me for 3 minutes, more 3-4 minutes? 3 minutes, sir.
Okay.
Okay, sir, I don't go details discussion of the ST segment, what are the changes. I just say persistent transient ST segment depression is more important to determine prognosis in case of non-STMI. Transient ST elevation also important, but T wave change and may be normal. You can find ECG 30% is normal in non-STMI. And this is the ESC from this message from ESC guideline, but I don't give you details. Just I go to the straight away some questions, and these are the findings. Which may ST segment depression more ischemia and it improves. It may correlate with prognosis, but you have not totally correlate prognosis with more than 5 leads involvement, then it may mildly impair correlate with prognosis. And if you look at this ECG, this is my point. This is the Wallen type, and this is De Winter, and this is the Wallen type. These also STMI equivalent. We should give emphasis on the top of non-STMI. We should treat as STMI equivalent so that we can save our patient's life. and we can reduce morbidity and mortality. And as well as now, my question to our fellows are, it is our time to knock our brain. 60 years old male, history of diabetes, COPD, chronic kidney disease, admitted COVID-19 and sepsis. Stable hemodynamics with SpO2 90%. Patient antibiotic already started. Patient had shortness of breath on admission. That has now improved. ECG shows sinus rhythm with non-specific steady changes. 2 set of troponin done, mildly elevated, 1.5 nanogram per ml. So what is our diagnosis? It is type 1 MI or type 2 or type 3 or type 2. That is the pool, sir.
Right.
Should I start the poll?
Pool.
Okay.
Only 20
Yes.
seconds.
Okay.
Is there any ECG?
Now, this is just sinus rhythm with non-specific steady change. Troponin just mildly elevated. Patient, COVID sepsis patient with multiple risk factor, with multiple comorbidities, hospitalized patient. Excellent, excellent. I quickly move the next slide. So all you know, type 1 and type 2, by definition, I don't go details, and you know elevation of troponin. And now question is, how do you know the type 1 is non-STEMI? I just tell one word, very florid and serious presentation of type 1 MI, acute setting, patient made dynamic ECG changes, and troponin is very, very high. So it may suggest type 1 non-STEMI or type 1 MI, but the answer is you go for, until and unless you go coronary angiography, you can't say it is type 1 or type 2 MI. Anyway, either when we should go, the question is asked by our senior colleagues, does the patient need to go to cath lab? Hafiz Bhai or Atar Ali sir asked, if you work in Feni, what should you do? If it is very high risk, we should go to the cath lab. When will you patient go to the cath lab? Once you start anticoagulation, antiplatelet, patient, if you find your cath lab okay, then you try to send your patient into cath lab. And what medication does the patient need? I just show you the slide, then I can discuss. This is the another question. If patient is very high heart score, TB score, GRACE score, having active chest pain, cath lab not available in your facilities, what will you do? Either you should call police to save you, or continue medical management, or transfer patient to hospital in the cath lab, or facilities there, or give thrombolytics therapy as discussion our senior faculties, or run away. Rivo, go to the poll for 20 seconds.
Yes, sir. Started the poll.
আজম, তোমাকে কিছু মনে না করলে একটা কমেন্ট করতে চাই।
হ্যাঁ, মনে করবো না, এটা
হচ্ছে কি যে নন স্টেমি আমরা যদি কমিটমেন্ট করি, এই যে নামে কি এসে যায়, নন স্টেমি মানেই কিন্তু টাইপ 1, কিন্তু টাইপ 2 হলে আর নন স্টেমি নাই, ওই টাইপ 2 এমআই। আমি বলতেছি আমাদের এখানকার বিলিং অনুসারে, বুঝছো? কারণ হলো যে টাইপ 1 এমআই এর ভিতরে স্টেমি নন স্টেমি ইনক্লুসিভ। টাইপ 2 এমআই on its own right, mixed bag.
হ্যাঁ, আপনার সাথে আমি একমত, কিন্তু যদি আপনি ইউনিভার্সাল ডেফিনিশন ক্রাইটেরিয়া দেখেন, এমআই ক্রাইটেরিয়া ওখানে এবার ওই যে 2017 তো এসটিএমআই ক্রাইটেরিয়া কিন্তু ডিফাইন করা আছে। এখানে আপনি টাইপ 1 টাইপ 2 মেইনলি বলাই হচ্ছে যে ক্রাইটেরিয়া অনুসারে বলা হচ্ছে,
রাইট? কিন্তু এই জায়গায় আমার সাথে বাহাস করলে পারবা না। টাইপ 2 এমআই মানে হলো that is not a non-STEMI by itself. Pathophysiologically, you are committed that this is type 1 MI. Type 2 MI is different. It's a mixed bag.
Type 2 MI, Hafiz Bhai, by definition, actually myocardial injury secondary to imbalance between demand and supply. What about the pathophysiology?
Yeah, hypoxia or hypoperfusion related.
Huh?
Hypoxia or hypoperfusion related injury.
আজম
giving
তোমার টাইম
troponin
কিন্তু
type.
অনেক বেশি কভার হয়ে গেছে ভাই।
হ্যাঁ সেটাই বলছি যে বেশি ডিসকাশন।
স্যার এখানে একটু কনফিউশন হলো স্যার, আইদার টাইপ 1 এমআই, টাইপ 2 এমআই, টাইপ 3 এমআই, it is not a non-STEMI. Type of MI, type of MI, types of
Correct.
5 types of MI, not types of non-STEMI.
Correct. That is I'm trying to say.
আমার মনে হয় আমরা we should go to the literature. আমার মনে হয় we will get the answer. We don't make our audience confused. Myocardial infarction on the top of ECG, you categorize ST elevation MI or non-ST elevation MI to get your strategy, either you go to primary PC or not, or like this. Whatever the situation.
চৌধুরী আহসান,
আজব সেজন্যই বললাম এটা এই বাস অন্য সময় করব। ঠিক আছে।
আচ্ছা, এটা অসুবিধা নেই।
আমার মনে হয় যে মানে this forum will arrange a good discussion on the classification and the different issues of the MI, particularly ST and non-ST MI.
No one can claim it is only dedicated for ST-MI classification.
Right.
From the universal definition, right? No one can claim it is no one's personal property. It is universal property. So
No.
I think
the classic universal definition of MI, myocardial infarction universal classification, type 1, type 2, type 3, type 4, type 5. Type 1 is inclusive of STEMI and non-STEMI. Type 2 MI is not by definition non-STEMI.
That is correct.
Because non-STEMI is pathophysiologically arterial wall plaque related, plaque rupture, plaque erosion, activation of the coagulation cascade, etc. Type 2 MI is completely different, hypoxia, hypoperfusion related, nothing to do with the arterial wall. That's they're going to say. It's very important because the management is different.
But
Azam, we have to go ahead. Azam, we have to finish it.
Okay. So now it is just one high risk PCI patient.
No more pause, please.
Okay. No more. We'll just go to the 60 years old female non-STEMI patient, diabetic, hypertension, hyperlipidemia. Went a PCI to left circumflex artery. Her ejection fraction was 55%. And what are the medications she should be on? But I just give the question as because Dr. Aziz raised the question, what is the management strategy? Aspirin, clopidogrel, beta blocker, nitrates, or aspirin, ticagrelor?
Azam, you can please. You have to go ahead with the just message, please. And we have another portion. We will be missing that.
Okay. Then I just go to my conclusion slide.
If you please.
Okay.
Because actually it was very lively discussion, but we have to go ahead. Hey, yes, please.
Okay, what is the medical management? This is the issue, aspirin, heparin, clopidogrel. But my message is prasugrel is only PCI patient. Prasugrel not in patient with stroke or transient ischemic attack patient. And we should go for DAPT. This is my very, very important message. Consider high risk patient, diabetes, vein graft, and low ejection fraction patient. We should continue at least 1 year. If during this case incomplete, then we should go for this ejection. We should continue at least DAPT 1 year. And this is my final slide. Beta blocker, you should start calcium channel blocker, SC inhibitor, whatever you like. This is my in-home message. Hafiz bhai, all non-STEMI are not the same. This is my first message. Non-all STEMI are not the same. The clinical presentation is the paramount importance should be given. EC changes in combination with positive troponin, highly suggestive of non-STEMI. Be aware of mimics. Troponin elevation does not mean the patient has to go to cath lab. Higher the risk, more the benefit of revascularization. DAPT at least for 1 year after non-STEMI, even if they did not receive any stent. Don't forget SC inhibitor ARB, especially for low EF and diabetic patient. You should intensify your statin therapy. And as because we are physician, we believe in evidence-based medicine. So we never forget to tell our patient, take all medicine or take all evidence or take all pills daily until new clinical trial is published. So I think I should stop here. Thank you very much.
Thank you.
So Azam, not all MIs are equal. That's the first thing. Not because MIs have different types. and then because not MIs are equal, so different MIs, not non-ST elevation, all non-ST elevations are equal. I agree with you. And the job is to define the low risk, intermediate risk, high risk crash and burn patients in the non-STEMI group. But non-STEMI by definition is type 1 MI. And we need to tease out who in that group is low risk, intermediate risk, high risk. But if we have a question about the patient is MI, is it non-STEMI or not STEMI or type 2, we'll have to think about the clinical picture, because that is really tough. Because if there is an easy explanation for a hypoxia related troponin rise, that is type 2 and that is not non-STEMI, and that is different. That's what I wanted to say.
Okay, I want to just for clarification.
Thank you, Professor Azam. It was a very lively discussion, and the participants have joined very actively. Atar Bhai, for the next session, will you be doing telling something?
Can I ask a question?
Sure, sir.
Oh, Rafiq sir has joined. Sir, welcome.
Just like, thank you. My question is, what percentage of population of Bangladesh has access to first PCI, second primary PCI?
Sir, I think less than 1%. That would be the correct answer.
Okay, so if that is the situation, but every time I attend a meeting in Bangladesh, we talk about bifurcation angioplasty. I am yet to attend any meeting where there is big discussion about medical management, including thrombolytics. Why is there such a gap between DLET and teaching? It's just a question to you all. And do you think we should answer that question? Because we have to solve 99% of the population, not 1%. 1%, yes, we need to strive to increase that 1% to 99%. But until that time, don't you think we should emphasize on those issues?
Question ta bozlam na Ravi bhai.
Question is, 99% of the population of Bangladesh have no access to primary PCI or PCI. Yet, when I listen to conversations, we always talk about angioplasty. I don't see much discussion about use of thrombolytics and medical management as much.
No, Rafiq bhai, we talk a lot about pharmacoinvasive also in Bangladesh.
Sir, Ravi sir, question.
But don't you think we should?
Sir, Ravi sir, question.
I think
স্যার যে আপনি ডাটাটা চাচ্ছেন বাংলাদেশের, প্রথম কথা হচ্ছে আমাদের গ্রিন কার্ড ডাটা নাই, এক নম্বর কথা। দুই নম্বর কথা হচ্ছে ইন্ডিয়াতে যে ডাটাটা আছে আমি বলছি, গত মাসে এনআইসি তাদের রিপোর্ট পেশ করেছে, তাদের হচ্ছে আপনার 6% প্রাইমারি পিসিআই হয়েছে ইন্ডিয়াতে। 6% ইন্ডিয়াতে প্রাইমারি পিসিআই হয়েছে। বাংলাদেশে আমাদের ডাটা নাই প্রাইমারি পিসিআই, এবং আমরা এজিউম করতে পারি, আমরা ধারণা করছি less than 1%, actually 1% হবে না, 0.5 to 0.6% like that. আমাদের যে স্যার কি বলেন?
No, I agree with you. Definitely, that's probably the right number.
Number one, sir. Number two হচ্ছে স্যার, most of the country আমরা সেটা মেডিকেল ম্যানেজমেন্টে আমরা করছি, যেখানে ফ্যাসিলিটিস আছে, যারা অ্যাক্সেস টু হেলথ কেয়ার ফ্যাসিলিটিস যারা অ্যাওয়ার্ড তারা হয়তো নিচ্ছে, তাদের ক্ষেত্রে আমরা প্রাইমারি পিসিআই এর কথা বলছি এবং এটাকে আমরা এনকারেজ এবং স্টিমুলেট করার চেষ্টা করছি। বিকজ রিয়েল ওয়ার্ল্ড সিনারিওতে এভিডেন্স বেসড মেডিসিন যেটা আছে, যে এটাতে বেনিফিট বেশি, এটাকে আমরা বলছি। আমাকে সত্য কথাটা আমাকে বলতে হবে। অল্টারনেটিভ অ্যাপ্রোচ তো আমরা করছি ম্যাক্সিমাম, টিচিংও আমরা ওইটাকেই বেশি প্রায়োরিটি দিচ্ছি, এবং আমরা বিশেষ করে ফার্মাকোইনভেসিভ অথবা আফটার এমআই পরে আমরা কখন আমরা ইন্টারভেনশন করবো সেটাই বলছি। আমরা কিন্তু সবসময় যে পিসিআই করতে হবে এটা আমরা জোর দিচ্ছি না স্যার। এটা জোর দিলে তো আমরা মানে আমাদের যে বার্ডেন সেটা আমরা কিন্তু মেকআপ করতে পারবো না।
All right. With the permission of chair, I have a question, sir, if I permitted. Just a minute. Am I permitted, sir? Professor MJ Azam.
হ্যাঁ, শিওর, বলেন, আপনি কোশ্চেন করেন।
আচ্ছা, regarding antiplatelet therapy, Use of antiplatelet continuation, you have to say the 1 year dual antiplatelet, either aspirin clopidogrel or aspirin prasugrel or aspirin ticagrelor. Which one is both best modalities? And another things in triple thrombotic therapy, antithrombotic therapy, like dual antiplatelet plus NOAC. Is there any role in case of non-ST elevation MI or ST elevation MI after stenting or without stenting?
আচ্ছা, এখানে আমি জানি না আমাদের কতটুকু টাইম আছে। I'd be happy to answer that question, কিন্তু ডক্টর ওয়াদুদ আপনি কি নেক্সট স্টেজে যাবেন নাকি আমরা এই প্রশ্নটা
না,
অ্যানসার করব?
আমরা আজকে আসলে এই ডিসকাশনটা এত ইন্টারেক্টিভ এবং এত
Wide,
হচ্ছে, আমরা আসলে শুধু এটার উপরই ফোকাস করে রাখি। আপনি বলেন আজিজ ভাই।
আচ্ছা শুনেন, জিনিসটা হচ্ছে কি, yes, dual antiplatelet therapy is extremely important. যদি thrombolytic therapy দেওয়া হয় তাহলে clopidogrel is the drug of choice, only drug that we have enough data for safety and efficacy. Clopidogrel যদি thrombolytic therapy দেওয়া হয় তাহলে age is the defining factor. If age less than 75, then you give 300 milligram as loading dose. If age is more than 75, you give 75 milligram as loading dose. Then you continue 75 milligram a day, preferably 1 year. If the patient needs any surgery or have bleeding issues, then at least 14 days. যদি angioplasty হয়, stent বসানো হয়, তাহলে আপনি ইউজ করতে পারেন any of these three, like clopidogrel, prasugrel অথবা ticagrelor. কিন্তু prasugrelর ক্ষেত্রে একটা জিনিস খেয়াল রাখতে হবে, you have enough data of safety and efficacy. জিনিসটা হলো কি, যদি পেশেন্টের স্ট্রোক থাকে, হেমোরেজিক অর টিআইএ থাকে, তাহলে prasugrel দেওয়া যাবে না। যদি এজ 75 উপরে হয় তাহলে prasugrel ব্লিডিং রিস্ক বেশি। Ticagrelor, I think you can still use that, but if there's a bleeding risk, then you need to be careful with the ticagrelor also, but still we have enough data on that. আচ্ছা, ট্রিপল থেরাপির ব্যাপারে যেটা, যদি পেশেন্টের এট্রিয়াল ফিব্রিলেশন থাকে, যদি পেশেন্টের মেকানিক্যাল ভালভ থাকে, পেশেন্টের কোগুলেশন ডিসঅর্ডার থাকে, ডিভিটি অথবা পুলমোনারি এম্বোলিজম থাকে, তাহলে সাধারণত আমরা ওই ধরনের পেশেন্টকে অ্যান্টিকোগুলেশনে রাখি। হ্যাঁ, যদি মেকানিক্যাল ভালভ থাকে তাহলে ওয়ারফারিন ইজ দ্য চয়েস, ইউ ডোন্ট হ্যাভ নোয়াক এনি চয়েস। So in that situation is definitely we have enough data. If you put on triple therapy like aspirin, Plavix, any P2Y12 inhibitor or an anticoagulation, the risk of bleeding is higher. In these patients, in this type of patients, if they are low risk patient, then we give aspirin during the hospital, like triple therapy. Aspirin, যখন স্টেন্ট বসানো হলো তাহলে aspirin এবং P2Y12 এবং অ্যান্টিকোগুলেশন, এটা either warfarin অথবা যদি নোয়াক দিতে হয়, বেস্ট ওয়ান ইজ প্রবলি এলিকুইস অর অ্যাপসিক্সিবান, যেটা আমরা বলা হয় অ্যাপিক্সোবান। সো অ্যাপিক্স এইটা আপনার আমরা ট্রিপল থেরাপি অনলি ইন দ্য হসপিটাল দেই, হসপিটাল ডিসচার্জের সময় আমরা অ্যাসপিরিনটা ড্রপ করে দিচ্ছি, and that's the current recommendation. এবং P2Y12 and anticoagulation, you continue that whole year, then you drop the P2Y12 and start back low dose aspirin and continue the anticoagulation. আচ্ছা, আর যদি আপনার ধরেন মেকানিক্যাল ভালভ থাকে তাহলে আপনার ওই ওয়ারফারিনের সঙ্গে ওই either P2Y12 যে কোনো একটা দিতে পারেন। তবে প্রশ্ন হচ্ছে কি, যদি as mentioned above যে যদি মেকানিক্যাল ভালভ না থাকে তাহলে অ্যান্টিকোগুলেশন ইজ দ্য চয়েস, ইজ এপিক্সোবান। হ্যাঁ, যেটা এলিকুইস, দ্যাটস দ্য বেস্ট রেজাল্টস আমরা দেখতে পাচ্ছি ডেটা, যে লেস রিস্ক অফ ব্লিডিং। হ্যাঁ, তবে যদি হাই রিস্ক পেশেন্ট আছে, যেটা হয়তো চৌধুরী হাসান বলতে পারবে, যদি লেফট মেইন স্টেন্ট বসানো হয়, মাল্টিভেসেল স্টেন্ট বসালেন, হ্যাঁ, তাদের রিকারেন্ট স্টেনোসিস, তখন সাধারণত আমরা অ্যাসপিরিন, P2Y12 এবং অ্যান্টিকোগুলেশন 1 মাসের জন্য দেই, অথবা অ্যাটলিস্ট 2 উইকসের জন্য দেই, পরে অ্যাসপিরিনটা ড্রপ করে দেওয়া হয়। তো এখানে হয়তো আসান একটু কমেন্ট করতে পারে, কারণ দে আর ডিলিং উইথ দ্যাট অন এভরিডে বেসিস, বাট দ্যাটস দ্য কারেন্ট রিকমেন্ডেশন রাইট নাও। হ্যাঁ,
সো আই এম নট শিওর।
আজিজ ভাই, আমি ক্যাট করতে পারি?
হ্যাঁ হ্যাঁ।
আচ্ছা, এই যে গোবিন্দদার প্রশ্নটা যে হুইচ ওয়ান ইজ বেস্ট অ্যাকচুয়ালি এইভাবে প্রশ্ন করলে আমরা একটু বিব্রত হয়ে যাই আর কি হুইচ ওয়ান ইজ বেস্ট ইট ইজ ইন্ডিভিজুয়ালাইজড অ্যাকচুয়ালি রিকমেন্ডেশন তো সবগুলো আছে যেটা বলা আছে যে আসলে আমরা তো এভিডেন্স বেসড প্র্যাকটিস করি আমরা তো বিভিন্ন ট্রায়ালে দেখি কোনটাতে ইফিকেসি কোনটাতে আউটকাম কতটুকু কি আছে না আছে সেটার উপর ভিত্তি করে আমরা সিদ্ধান্তগুলো নিই আপনার যে কথা ছিল কোশ্চেনটা ছিল
Ajam, English please. Nepalese students are here.
কোনটা স্যার
Nepalese students, colleagues are here.
ও আচ্ছা স্টুডেন্ট আচ্ছা সরি অ্যাকচুয়ালি স্যার এটা ওকে এই যে our DAPT strategy should be individualized on the basis of evidence. What evidence we have, we should prefer aspirin first, then you can choose P2Y2 inhibitor, whatever you like, whatever you feel. But caution is that you should not choose prasugrel firstly. Either you should choose clopidogrel or ticagrelor. This is the one issue. Second issue is triple therapy regarding. You should consider triple therapy only when patient on in atrial fibrillation or prosthetic valve is there. Then you should consider this issue. I think that these two issues we should remember, and everything is nicely stated in the EC 2000 non-STEMI guideline recommendation. How long you should continue. Thing is that if it is very high risk, left main, if lesion more than 60 millimeter, venous graft or bifurcation lesion, then you should consider whether you should continue 1 year more or not. Then you should decide on depth score. Before, if it is very high in this score, then you should go for precise depth score. Then you make scoring system. How long you should continue, which drug you should prefer, because which bleeding complication is less or more, then you should decide your antiplatelet strategy. That is my take-home message.
Thank you, Professor Azam. Professor Abdul Wadud Chaudhary.
Today, actually, we have a very discussion which more centered on the management and different type of presentation of non-STEMI. We did not actually focus only on the ECG presentation. But as Professor Rafiq sir has pointed out, for our country's context, we should be focusing more on the pharmacotherapy, the medical management side to save lives. And then proceed to do what the guidelines are saying when the resources are available. And that's the way we can actually serve two ends. But mostly to serve the whole population, we should be strengthening the idea about how to do, how to diagnose. Is it actually a non-STEMI or is it only cardiac injury? This type 1 to type 5 MI classification did not come only for classification. It actually comes because they determine the way we should manage this patient. They determine the prognosis of the patient, because if we were taking a different attitude for a different type, we may harm the patient. Today, I have a patient in my hospital who had typical presentation like left main. You know, the patient is CKD, she had a history of hypertension, diabetes, everything, but her hemoglobin is 3 grams. And she had all the evidence of infection. So should I be going for cath lab to this patient? No, of course not. I'm going to correct her, control her diabetes. I'm going to control her pressure, going to control the infection, correct the anemia, and only then I should think about taking the patient to the cath lab.
What was this patient's troponin?
Troponin is raised, but not that much. A 2.7 or something like that. Just came.
Yeah, I call it small troponin, mini troponin.
Exactly.
And this is not non-STEMI. This is not non-STEMI. This is type 2 MI.
Type 2 MI.
This is a very likely cardiac injury, type 2 MI. And that's the point we are making. From ECG, do not jump into conclusion that I should be doing this or that. Take the whole clinical context and then decide which way we should go. Thank you, everybody. When we have a very lively discussion. Rafiq sir, we really missed you.
I really need to add some comments if I may be given some time.
Please.
So following the MI, if we are doing any invasive angiogram and giving a stent following acute coronary syndrome, we have now plenty of data to suggest that dual antiplatelet with aspirin prasugrel or aspirin ticagrelor are superior to aspirin clopidogrel. This is no longer a debate. This is plenty of data. So it's not that we choose Plavix. If it is a financial issue or availability issue, that's I call social issue. The science is that this is far superior in terms of recurrent events. Now, in the European guideline, as Azam pointed out, that the ticagrelor has versus prasugrel, they actually put prasugrel little above the ticagrelor, which in this side of the Atlantic, we are still using both equally. And actually we are using now probably ticagrelor more. In Bangladesh context, as you know, we don't know actually how much antiplatelet we need. But in the genetics of the clopidogrel is that it is a prodrug. It is metabolized by the cytochrome 2C19. So if your genetic constitution is such that it does not convert the drug to the active moiety, the effectiveness of antiplatelet will be low. We have shown this in our study also. And if you give ticagrelor, it is not a prodrug, it works directly. And the prasugrel does not work with the 2C19. So polymorphism doesn't matter. So therefore, antiplatelet effect of prasugrel in our population will be much more predictable. We can achieve the antiplatelet effect peak early, and it is more sustainable. But everything comes with a price, and the price is bleeding. In the Triton trial, there was tendency of any history of TIA stroke, patient weight less than 60, and the patient is more than 75 years of age. Those had the higher bleed, and the FDA cautioned us, gave us the caution. It is not like absolute contraindication. Some at that point were believing that it is powerful antiplatelet. So if you have a significant overlapping stents, left main, etc., where antiplatelet effect is more needed, you use those situation compared to clopidogrel. But now in those relative contraindication, we use ticagrelor. And the duration is acute coronary syndrome from the historic cure data, cure PCI, 1 year we recommend generally, right? But it is the time of endothelialization. For the triple therapy without another indication for anticoagulation, I think that was Dr. Govindapal's question. Any addition of anticoagulation in addition to the dual antiplatelet, in the absence of an anticoagulation needed, there is no data. But if you need anticoagulation because of AFib, mechanical valve, then mechanical valve absolutely go for Coumadin. For AFib and PE and other indications, you can combine with the dual antiplatelet, and there we differ. Some people say that initial triple therapy may be 7 days to 4 weeks. Some will say before discharge, and that you can go back and forth. We usually give a month and then go to dual therapy with dropping the aspirin. So that's what I wanted to say.
Yeah, I'd like to make one comment here. We need to make sure that our fellows and attendees understand that prasugrel and ticagrelor definitely more data. This data with the stents, since in our country, we are using most commonly thrombolytic therapy. The data we have so far with the Plavix. The question right now whether we could use prasugrel or ticagrelor with the thrombolytic therapy, we do not have any convincing data right now about the efficacy for that. So that's we need to make sure we clearly distinct that. So prasugrel, so Plavix, prasugrel, and ticagrelor. If you compare these three, definitely prasugrel and ticagrelor, they're better with all the data we have with the stents. But with thrombolytic therapy, still Plavix is the drug of choice so far, unless we have new data comes out.
And Aziz Bhai, I really agree with that. But you remember that in the COMET trial and the Chinese COMET equivalent, they there was a criticism that they were not probably brave enough to give enough antiplatelet, but it comes with a price. We don't know yet. Yeah.
Yes, that's correct. Yeah.
But in our population, I will say maybe Azam, you can do a registry nicely that probably better, I would argue, to give non-clopidogrel agent if we can.
Sorry, I missed your point. Hafiz bhai, please, can you repeat again?
The point
No, we are
Hafiz is
doing-
making that if possible, if the patient can afford it, ticagrelor or prasugrel combination with aspirin will be more effective and more actually life-saving. That's what he is saying. Because there is some studies has been done in Bardem, which shows there is at least 40% clopidogrel resistance. Though in clinical context, we do not have that much of clopidogrel failure, but the reality is there is a significant number of patients have clopidogrel resistance. Hafiz bhai, are you alluding to that study?
Was that other?
Bardem has done a study, Maksum bhai et al, they have done a study. They have shown around 40% of our patients have clopidogrel resistance.
Sir, is a Maksum sir data jeta chilo প্রায় 30 থেকে 35% ছিল স্যার।
35 থেকে 40% পর্যন্ত আসছে তাদের।
Well, I just wanted to remind you that the whole study design was mine and I was involved in that study.
Yeah.
So you can ask me the question.
And
I brought the Echometrics machine from US to do the P2Y12 actual the PRU value there. And we actually did another interesting thing, which is the guide sample taken and see the platelet activation following the balloon inflation. And we published this in World Congress of Cardiology anyway. So one of the important thing that we did, and it was later, that those cohort where we saw less antiplatelet effect and the normal antiplatelet effect, the samples taken and in University of Seoul, Korea, we did the genetic analysis and did a mutant gene. And our number is far higher than the Caucasian population.
Yes.
My question to Dr. Hafiz, if anyone continue to do APT, clopidogrel and prasugrel or clopidogrel, ticagrelor, do you recommend it?
In what? Azam?
DAPT regime.
Yeah.
If anyone can choose clopidogrel and ticagrelor, do you prefer it? Do you recommend it? Right.
No.
So
Clopidogrel and ticagrelor.
Ecosprin, and you can either add clopidogrel, prasugrel, or ticagrelor, whatever you like. I think this should be the.
We learned from the combination chemo, right? Combination chemo. The basic principle is that mechanism should be different if you want to get an effect.
Right.
Clopidogrel and they work in the same receptor. In the aspirin with the acetyl salicylate part combining with cyclooxygenase. We are far beyond EKG.
Yes.
Professor Chaudhary.
Atar bhai, I think we have enjoyed the session very nicely. Would you please conclude?
So really, it was a very, very brilliant presentation, excellent discussion, and lots of our panelists and faculties participated in the discussion. Actually, we could continue the session for I don't know, the indefinite time. Professor Azam initiated such a beautiful discussion. His ECGs were very, very excellent, beautiful, really. Actually, it was what I say, that is the brilliant, exceptional presentation. Congratulations, Professor Azam. Just an announcement, the next Sunday, our National Morning Day. So next Sunday, there will be no program of the ECG we have the ECG study group. Next Sunday, that is 15th August, National Morning Day. So at that day, there will be no ECG study group program. The following Sunday, 22nd of this month, there will be a session. And instead of Dr. Tushar, I like to request Dr. Abdullah Jamil. We are very sorry, Dr. Abdullah Jamil, we can manage a time for you today. And I will request you to say something after my talk. Dr. Abdullah Jamil, you are requested to present your cases in 22nd of this month. And review, please note, Dr. Abdullah Jamil and Dr. Arun Maski will be presenter at that day. So, Dr. Abdullah Zamil, we are sorry. Everybody enjoyed this discussion today, so we could not manage time for you. So next Sunday, National Morning Day, no program. 22nd of this month, Dr. Zamil and Dr. Tushar will be. That is the Urun Mask will be the presenter. So with this comment, I like to conclude the session. Dr. Zamil, do you want to say anything?
Sir, I want to take the one more advantage to talk with Dr. Arun Maski, sir. Can you allow me 1 minute, sir?
Okay, MZ Azam.
Dr. Arun Maski, can you hear me?
Possibly he has left.
Okay, possibly. Okay, sir. I just give you a personally message. Thank you, sir. Dr.
Jamil, we are going to conclude the session. You are our second presenter, but we could not manage time. Do you? We will be the presenter on the 22nd. Do you have any comment?
No, sir. Thank you.
So thank you very much, Dr. Abdullah Jamil, and we can conclude the session and we can leave and we can actually, I am inviting everybody, Dr. Azizul Haq, we are very much proud to see you and thank you very much for your contribution.
Thank you.
Discussion. Really, and I can see that Dr. Shofiq Rahman Patwari, congratulations, Dr. Shofiq Rahman Patwari. We are happy to see you again. And Khandakar Asadul Zaman, Anisul Awal, everybody. So we can conclude the session. Abdullah Chaudhary.
Thank you, sir. We'll be seeing in a fortnight's time. We'll be meeting again. Until then, let us hope all of us remain quite healthy.
Again, big congratulations, MZ Azam. Big congratulations. Thank you very much.
Thank you, sir. Thank you, Professor MZ Azam.
Assalamu
Have a good
alaikum.
night, sir.
Good night.